because Tedros, who's the head of WHO headquarters is in Geneva, but WHO is made up of regional offices. So there's 5 regional offices, one of them being PAHO, the Pan American Health Organization, which predated WHO. So PAHO was created when the Panama Canal was being built, partially to work on coordination for the control of tropical diseases like yellow fever, which was preventing the Panama Canal from being. So when WHO was created, PAHO demanded that it has a lot of autonomy. So all the regional offices have quite a lot of autonomy, which makes actually WHO a very difficult structure to work with, because even though you agree with something at headquarters, it doesn't mean that the regions agree. And then they have country offices, but they really generally produce basically normative guidance. And I mean, that's sort of their role as a technical agency. They do have a health financing department. Some of you may know Joe Cutson. He's the head of health financing at WHO. He's quite a well-known health economist. And, they have other parts, that they work on financing of primary health care. They do work on national health accounts, which is the standard way for expenditure tracking for WHO. They work on health financing strategies and some other things. But they're really organized much more around clinical areas. They're different academic clusters. I mean, they're different clusters around disease areas like AIDS and tropical diseases. And now the biggest part of WHO is around health security. So there's a big part. But I think one of the issues always for WHO is that since they don't really have any money, it's very hard for them to be influential because they can't necessarily back up their advice with money. So that's always been an issue. So it's like an issue once that Stalin once said about the Pope, that he has a lot of influence in the world, but how many tanks does he actually have? So now I can't move. Now I can't move the slides. Oh, there we go. No, it works. Okay, so that's one class. I'd say the other big player is kind of the multilateral development banks. So they actually lend usually like across all different areas, not just health. So they're working across like the infrastructure, they're working on all of the social sector, like education, they're working on the energy sector. But they have, and all of them have rising social sectors. So, and the World Bank is the largest of them, but they have a much stronger connection to the Ministry of Finance because it's loan financing and it has to be agreed with the Ministry of Finance to actually take out loans. But there's not just the World Bank, there's a lot of regional development banks. There's the Inter-American Development Bank, the Asian Development Bank, the African Development Bank. Actually, there's bilateral development banks, like the Japanese. Many countries have their own, the French. And then the Islamic Development Bank, which is I'm going to talk a tiny bit about because we've been doing some work on blended finance with the Islamic Development Bank. The next class are these kind of new health funds. I work for one of them, the Global Fund. The first one was Gavi, the Global Alliance for Vaccines and Immunization. It provides basically funding for countries, low-income countries, for new vaccines. So all the new vaccines that are being developed, like say there's a new vaccine for cholera or various other things, they will fund those vaccines actually. So they're not generally providing funding for already existing vaccines, but then they have a whole vaccine strengthening program because they work on supply chain to make sure that they have an adequate, and they work on sort of trying to increase the reach of the whole vaccination program. It's funded by all the different bilateral donors, but also the Gates Foundation. Then there's the Global Fund, which sort of provides about $5 billion a year in grant financing. So that works specifically on AIDS, tuberculosis, and malaria. That was created in 2003 when there was a crisis, particularly around AIDS, and the price of ARVs was extremely expensive for low-income countries, and it was critically important to get sort of AIDS drugs to South Africa and other countries in Africa that were suffering like a terrible epidemic for AIDS. For complex political reasons, that they decided to add on other priority diseases, including malaria and tuberculosis. So that actually gave the Global Fund a wider reach, which means that it also works on health systems because it's also working on the 3 diseases. And then what we at the Global Fund call resilient and sustainable health systems. So working on health system strengthening that, particularly for areas that are important across the 3 diseases. So that might be community health workers. It could also be other sort of parts of the system like supply chain, health information systems. So we work in these areas. More recently, about 5 years ago, a new program was created called the Global Finance Facility, called the GFF. So the GFF sits at the World Bank, but is a separate secretariat, and it covers reproductive and child health. It actually covers a much wider thing. It includes neonatal health, it includes adolescent health, it also includes nutrition. It's very closely linked to UNICEF. But it's actually a financing facility that sits at the World Bank. And actually, as we talk about blended finance, one of its roles is to blend grant financing from the GFF with the World Bank so that you can add increased concessionality, which I'll be explaining. So that's kind of almost for one of the selling points of the GFF is that it actually does finance, but it's supposed to be particularly in the area of maternal and child health. There are a couple of new ones. Well, the oldest one is the global program on polio eradication. Sadly, polio is almost eradicated, like smallpox, but there's still a couple of countries, including Pakistan and Afghanistan, that still have polio. And then obviously all the countries that have eliminated need to continue surveillance. So there's a big program that's financed largely by the Gates Foundation and the Rotary Club. And that's a global vertical program, really, that actually really is very specifically focused on polio. The most recent creation last year is this new pandemic fund that sits at the World Bank. It's supposed to fund countries' pandemic preparedness. It's a fiscal intermediary fund that sits at the World Bank. The World Bank holds the secretariat, but there are many different implementing partners from the pandemic funds. That includes even the Global Fund is one of the implementing partners with the World Food Program and UNICEF and WHO. So as you can see, we have a plethora of development banks. We have all these different funds and stuff like that. And then we also have non-state actors. So we have a lot of different international NGOs active, like Amnesty International, Oxfam. We have like big philanthropies like the Gates Foundation. We have the Wellcome Trust. So those are really non-state actors that have like a lot of influence in the system, particularly the Gates Foundation and the Wellcome Trust are major funders. And the Gates Foundation funds all the different parts. It funds the Global Fund, it funds GAPI, it funds all different parts of the system, stuff like that. So I mean, it's worth thinking a bit about the Gates Foundation because in a way like Microsoft, I mean, it does in a way because it's so large actually have like undue influence over the system because many other donors that have been active in the health field, because the Gates Foundation is so large, have kind of withdrawn actually. So the Rockefeller Foundation, which really has a long, illustrious history working in health, really doesn't work in health anymore, actually, because the Gates Foundation is so dominant, actually. So, and they fund most aspects of health. The foundation is active like almost everywhere. I mean, but it doesn't actually fund non-communicable diseases. So it really only funds infectious diseases. So it doesn't fund mental health or diabetes or hypertension, which is actually the burden. Interestingly, obviously the largest cause of the burden of disease, not only for high-income countries but also for low-income countries increasingly. So one of the things that's obviously most interested in is new product development. That's always been sort of the kind of Gates Foundation, kind of American ethos, better living through chemistry, applied technological advances. So they fund a lot of new product development, like in diagnostics for neglected tropical diseases like malaria, TB, and stuff like that. So they are an outsized player in this very complex environment. So if I can get this to work, actually. So yeah, that does work. So I think that what's been happening now, and one of the reasons I want to talk about blended finance, is a very difficult coordination problem to work with so many different partners and countries together. So how can you actually do that in an effective manner? And what might you do to achieve that? I'm going to try to argue that one of the ways to do that is by blending finance together. So blending like what the Global Fund does, which is grant financing, with what the World Bank and other multilateral donors, development banks do, which is loan financing. Put those two pieces together, and you could actually get more money in health, but more health for the money because you'd have a more harmonized approach that was more aligned with country systems. And that goes through the Ministry of Finance and uses government systems and is therefore a more sustainable pathway for development. So, and what I would say is that all of the different partners that I've explained that work in different areas, like I work at the Global Fund, we all need additional funding in order to achieve the objectives that we've set for ourselves. So in the case of the Global Fund, it's to eliminate AIDS, TB, and malaria. There's not enough money to expand ARVs or bed nets in malaria to all the countries. So there needs to be increased funding. Obviously, that funding needs to be used also more efficiently, but there's a need for increased funding. So where's that money going to come from if overseas development aid is actually not only not increasing, but actually potentially even declining? So that one of the explanations for why we would want to do blended finance is to increase funding, and that's really to at least in the case of the Global Fund, would be to help countries transition out of the Global Fund as they move to higher income status, or to transition certain parts of the program to government systems, to cover some big funding gaps, say, for example, for pet nets or something like that, but also to work on service integration, because I think that there are inefficiencies created by this donor architecture where all the different systems set up their own system. So, I mean, the most extreme example would be supply chain. So if each part of the system is setting up its own supply chain, so you have a separate supply chain for vaccines, then you have a separate supply chain for AIDS drugs, and then one for TB, that's not going to be an efficient way to run a supply chain. And if you've ever seen diagrams of the supply chain, say, for example, in Kenya, it used to have all these different supply chains, and it was finally integrated. Because of the inefficiency of it. And you can think that that's true not just for supply chain, but it's also true for information systems and for human resources. Often programs hire their own community health workers. So those things all need to be integrated. And so looking to sort of ways of actually leading to system integration. Finally, I think I've been talking a lot about trying to get all these pieces of the global architecture together. We're the Global Fund, we're just one really small cog in a larger architecture, but then that architecture has to interface with the country architecture and actually make it work in country. So how you navigate that system is quite complex, and particularly for the Global Fund, which doesn't have any country presence. So we usually work through other partners. So we need to work with the World Bank because they have money and they are working help, but also we could work with WHO because they have people in country and have technical expertise and stuff like that. But there's also, other partners like the US government has PEPFAR and other technical programs. And what I'm going to be arguing is that instruments like a World Bank Health Sector loan could actually be used to actually advance Global Fund interests. And that's why we're going to make the argument to move to blended finance. So I'm just going to give an example, since to make it a little bit more concrete, because it seems like an awfully abstract idea, to walk through it like sort of an example of something I'm actually working on right now, which is a blended finance deal that I'm working on in Pakistan with the Islamic Development Bank. So I just want to sort of explain to you how it works. So the Islamic Development Bank is like similar to other lenders. They lend countries money, and that money eventually has to be paid back. One thing that's somewhat interesting is that in Islamic lending, you can't really pay interest. So they have Sharia lending. So basically what that means is that rather than pay interest, you kind of calculate what is roughly equivalent to the interest, and you pay that as an administrative fee. So it's not really that different, actually. So but you can't pay interest. So, and they have certain things that they seem to be more flexible about under Sharia lending, including paying some of the recurrent labor costs of the health system, which tends to be an issue in investment projects from the World Bank. So you have the ISDB, which lends basically to over 80 countries. The principal financiers, it includes basically almost all the countries in Africa, and then a bunch of countries in Asia, including Pakistan and Bangladesh and Indonesia, which are three very, very large countries. But it actually works in a surprisingly large number of countries. Morocco, Algeria. It works in places where there's like a Muslim minority. So actually Guyana and Suriname, actually. So it works in over 80 countries. And they generally do infrastructure projects. They don't do that much social sector lending. But in their new strategy over the next 5 years, they want to expand social sector spending. So social sector spending includes not just health, but health and education, and also social protection. But they mainly work in education. They've developed a partnership with the Global Program on Education, which is a bit like the Global Fund, but for education. And they've been doing a lot of work on primary education in developing countries. And they have a new priority to sort of expand their work in the health sector and to do more work on kind of maternal and child health and primary health. So the problem that they have is that they have to basically provide the money at basically close to market interest rates. So the government would have to want to borrow for the health sector at market rates. So the advantage of the development bank is they're more likely to lend governments that might be more at risk for defaulting, countries like Somalia or something like that. But also, it's like if they can find more concessionality to it, if they can actually lower the interest rate or find somebody to sort of co-finance it, then it becomes quite attractive to the Ministry of Finance. So in the specific case of the Islamic Development Bank, there's a fund called the Lives and Livelihood Fund that provides concessionality to Islamic Development Bank lending. So they actually would provide up to 35% to different eligible countries. That's actually going to probably even expand. So that means that the cost of the loan is like just they reduce it by 35%, generally by buying out part of the administrative fee, which is basically the interest rate. So that actually provides concessionality. So that makes it very attractive to the Ministry of Finance. So you have a loan where you then have like somebody paying basically the interest for you. And then you have other partners, in this case, the Global Fund, but it could be Gavi or the GFF, that provides additional grant financing. So it either pays off part of the principal, pays off the rest of the interest rate, but it can do a lot of other things. It can provide technical assistance to the project and work on all different areas like monitoring and evaluation. And if you put these pieces all together from the standpoint of the borrower, like the partners are all working together on an agreed approach. It's on budget, and you can do a lot more with such a bigger project. And you're actually in dialogue with both the Ministry of Health and the Ministry of Finance at the same time. So here's the specific case of Pakistan. So it was a polio project that the Islamic Development Bank was going to provide. The buy down would be provided kind of through the LF, through the Gates Foundation, to lower the interest rate. This was for procuring basically new vaccines. And then they have some actually support for systems issues like providing for the polio campaigns and various things. And what we wanted to do was add a community health worker component, but not just for community health workers who work on polio, but for universal community health workers. So Pakistan is a very interesting country. It was one of the first to introduce sort of idea of a community health worker called the Lady Health Workers Program. It was introduced by Benazir Bhutto during the period when reproductive health was like a very high on the global health agenda. There was the Beijing Plus conference, and they announced with great fanfare this basically nationally funded program to have women who were from the community trained in public health who would then visit households. And because it's a Muslim country, it's not so easy unless you're a woman, to enter into the sort of the household, particularly around reproductive health issues, including, maternal mortality and getting people to go who are pregnant, but also for reproductive health. And Pakistan has very, very low rate of contraceptive prevalence. So they had this program that was a flagship program of lady health workers across the whole country, funded nationally. Very, very successful program that increased outcomes, particularly for reproductive health. It increased contraceptive prevalence, but also improved the detection of, sort of issues in pregnancy. So it's good for the whole MCH system. They did work on child growth and various other things, immunization. But for complex political reasons in Pakistan, they introduced very radical decentralization. So when the system was decentralized, health became a provincial subject or a state subject, a bit similar, more like the United States or Germany, or India, where health is actually not really the province of the national or federal government, but the province of the provincial government. So this nationally funded program fell apart because it doesn't work in the provinces, and the actually recurrent costs for paying all the health workers, for the community health workers and the lay health workers needs to come from the provincial governments. And they actually, initially they balked at the issue and they didn't have the funding. And then eventually it was ruled that they had to pay for it. So they did start paying for it, but they didn't pay for any supplies or any supervision. And so the program sadly has really fallen apart in the last decade, in the last 5 years. And so this is an attempt to revitalize that program, but actually also to change away from reproductive health, to still obviously focus on reproductive health, but to actually cover all diseases, including in our case tuberculosis for the Global Fund, but in addition cover NCDs like diabetes and hypertension and mental health, and actually to give them cell phones, technology-enabled community health workers, which actually can really lead to very significant improvements in core indicators. And Pakistan demonstrated this already in vaccination with the EVAC program, where they had technology-enabled vaccinators in the Punjab, and they increased vaccination coverage from 40 to 80%. So kind of using that same approach, but a broader approach to community health workers. So we would actually pay for the community health worker program. We would pay for the kind of the funding of the software program, the buying of the cell phones, and the sort of those sort of investment costs and training and various other things. And also they want to do work on contracting out. So it's not necessarily that the workers are not necessarily directly controlled by the government, but actually contracted through NGOs, which is a form of social contracting. And so we would provide technical assistance. And then the ISDB would like pick up some of the other kind of core costs, but particularly the labor costs, like the human resource costs, which would then actually, they would work with the Ministry of Finance over time to transition that into government financing, and they would work directly with the provinces. So it's a really complementary set of things that come out of this, with our grant financing sort of funding what our kind of core interest is and complementing an ISDB project that's sort of working already in the area and adding on our area of interest to that. 5 minutes. I just wanted to go through a couple other examples, and now I wanted to switch to the World Bank, and I just wanted to explain a bit how the World Bank works, just so that you know, and then I'll just give some concrete examples to end on about how some other concrete examples of doing this together with the World Bank. So the World Bank has 3 different parts. One is the main part, which is called the IBRD, International Bank of Reconstruction and Development, and they basically fund things at market rates. So they fund middle-income countries and creditworthy low-income countries, and that's the largest part of the bank, $60 billion. Then they have something called IDA, the International Development Association, which gets replenished every 3 years, and that's basically grant financing, and it's used to lower the interest rate. So it's IDA money, and it goes to low-income countries, and at a certain income level, you transition from IDA to IBRD. So, and then the International Finance Corporation lends to the private sector, so not necessarily to government. So the first 2 are government lending. So if you're working in a low middle income country, say like Tanzania, you would get an IDA allocation. The IDA allocation goes to the Ministry of Finance and is used across all sectors and is used to kind of subsidize lending across all sectors. And the governments themselves decide how they're going to use their IDA money. But all the different parts of the World Bank and working with their own respective ministries are trying to get that IDA money, that sort of subsidized interest rate. And then the bank, just for people to understand, the way the bank is organized is that they're organized into regions. So they have like people in Eastern Europe and different parts of Africa, Africa 1, Africa 2, Asia. And they have offices in all the different countries. So they have a country office, usually with very good connections, like to internal stakeholders. Usually they have really excellent health people. They have a strong connection directly to the Ministry of Finance. And then they have somebody called the TTL, the task team leader. So he's responsible usually for developing a health sector loan. And then they have different instruments that you can use, like bank instruments, like an investment loan, and now increasingly what is called results-based financing. And usually you start by doing analytic work. You do like a report about like what's wrong with the health sector, and then that sort of highlights what's wrong with the health sector, and then you kind of develop a project that solves the sector. And one of the big advantages of the bank, say compared to other places like say WHO or others, is that it works across all sectors. So you can work on water and sanitation and sort of other areas like education, because it's a multi-sectoral bank. And generally, you have like sector investment lending. It's usually a 5-year project. Increasingly, they're moving away from a more input-based financing, which are usually sector investment loans, to program lending, program for results, where you pay for outputs, actually. So why would the Global Fund do this? Work together with the World Bank, actually. So, well, the Ministry of Health is very interested in taking out a World Bank loan, but say they're a middle income country now, or moving towards middle income status, or the health sector has not really been prioritized, so they can't really get access to this sort of subsidized IDA lending. Generally, ministries of finance are very hesitant to actually borrow in the health sector. Particularly, I have to say, if they were once part of the former Soviet Union or part of that cycle, because in Soviet economic theory, health is a non-productive part of the economy. actually. So it's seen as just recurrent costs, and there's no idea about human capital or anything. So like the Minister of Finance in Vietnam, for example, that's their view. Like, so they'll take it out, they'll take money, they'll borrow money, but not if it's subsidized. So if it's like this IDA low interest rate, they'll take it, but they're not very interested. And that's what happened in China. When China went from IDA to IBRD status, basically they stopped borrowing for the health sector. So they had a huge program of billions of dollars when it was IDA, but once they graduated to IBRD, they were no longer really willing to take out funding for the health sector. So, and in the case of the Global Fund, we could then work on broader health sector issues like health insurance and make sure that HCV and malaria in the package. We can work on primary healthcare reform and make sure those are integrated. We can rationalize specific things like labs and various things like that. We could do demand side incentives. So as I said, we want to try to put together IDA to IBRD. So I go back to this diagram, so basically a donor like us, we buy down the interest rate. We're paying part of the interest rate. And so we make a loan concessional. So we put money into a World Bank State Trust Fund. It provides concessional lending, and you get a health sector loan out of it. And then we can also provide technical assistance. And so this is a traditional bank IBRD thing. So about what you're borrowing. So you're borrowing, at market rates, and, so you're going to have to pay back all this interest. So basically, if we would cover those interest payments, that would be the way that you basically make the system work. So the first example of this was done by the Gates Foundation, the Rotary Fund in Nigeria for polio, to expand a polio program there. I'm not going to really go through that one because I didn't actually work on that one, but it was one of the most successful, and polio has currently been eliminated in Nigeria. There are other examples. There was this one I did work a little bit on, which was a TB control project in China. As I said, when China went from IDA to IBRD, they didn't borrow, and I worked at DFID at the time. Very peripherally on this, but we provided a buy down actually for the China TB project. So there are a couple that have been done. And then at the Global Fund, we've been actually pushing this. So the most recent one that I worked on is in Pakistan. I mentioned this ISDB one, but we already did a broader one on primary healthcare. And I've been working on something called the Sustainable Financing for Health Accelerator, which is a global health accelerator around the different partners, the Global Fund, Gavi, and the GFF, and the bank at WHO to coordinate around health financing. And we have done a lot of work on coordination to improve coordination around health financing dialogue. But in addition to that, we developed a joint project with the World Bank. It's a big primary healthcare project called the National Health Support Project. It's a payment for results project that goes to the provinces, and it strengthens primary healthcare. So the indicators for primary healthcare include immunization. So Gavi is happy. So they're putting money in. It includes maternal and child health indicators. So the GFF is interested. It has TB indicators. So the Global Fund is interested. And we are all putting in grant financing. And then the bank has, as you can see, I think it's 285 million in IDA, 258 in IDA. So we put these all together, and we're all part of a big package. We all go on missions together. And we're only putting in 5 million. Hopefully in the future we'll put in more, but it's a way also of channeling money together as partners. And then I just wanted to go through one last one, which I think is very interesting, one that we're working on right now with the World Bank around Colombia, Venezuelan refugees in Colombia, actually. So there are a lot of people, obviously, who've been sadly leaving Venezuela and going to Colombia. And many of those people are then not covered, by healthcare because they're refugees. And the way to sort of solve this problem is to get them registered into their health insurance system. Once they're in the health insurance system, then they get access to benefits, including to ARV treatment. So we're working together with the bank to try to accelerate registration of people living with AIDS and Venezuelans more generally, to get them into the health insurance system more quickly, and to increase coverage, therefore, of people living with AIDS. And so there's we have our own sort of program that's working in Colombia on Venezuelan refugees with grant financing, and the bank has a whole project where it's trying to improve the performance of the Colombian health insurance system and more broadly. And so we decided that we should try to combine forces, And so that with the new project, so they're planning a PFR, Program for Results project, like around $300 million. They're also getting this, there's a new trust fund at the bank for funding refugees. And then the Global Fund would put in money actually to fund people living with AIDS into this project actually. So it has a lot of different benefits for us, but it encourages sustainability of Global Fund interventions that are currently, grant finance that depend on our grant financing. Once our grant financing ends, so we see this as a pathway to sustainability. So I'm going to skip this one. I just want to say there are other ones we've worked with the Inter-American Development Bank. This is on a regional program for malaria elimination, where we actually put in funding together in Central America through BIDAM. I think that I'm just going to end, to not just make this all so rosy, that it's very, very difficult for these organizations to work together. And we've really struggled with a lot of different issues. I mean, just even getting to know each other, people don't necessarily need to really develop personal relationships kind of to work together, but we also have a lot of programmatic issues around timing. Our cycles are not aligned. We have like the way financial issues, auditing issues. So we have really struggled. And so it's not easy actually. And so that it partially explains, I mean, I do say that this seems like an obvious solution, but then why does it happen more? And I think that there's a sort of a complex political economy about why actually something that probably makes sense doesn't really happen. And it's worth reflecting on because we now have this new pandemic fund sitting at the World Bank, and it's supposed to, in a way, do a lot of the things that I'm talking about, bring more money into pandemic preparedness, because they don't really have that much money in grant financing. It's only like $1 billion or something. It's much less than the Global Fund. So it will only work if it works through blending and successfully is able to partner with other partners. So with that, I will stop and questions.
Great. So thanks everyone for coming today. We have apparently 98 people online. I'm not saying that means there'll be 98 questions coming your way. So
maybe we should start with questions online.
Yeah. So I've asked Carl to kind of consolidate the questions and send them over. So what I'll do in the meantime, I'm just going to get them on my phone.
Okay.
But I thought for those of you in the room, would anyone here like to ask a question to start things off? Yes.
Yeah, thank you so much. It was really insightful. I have a follow-up question. So you mentioned you work very closely with the World Bank Group because they work closely with the Ministries of Health or Ministries of Finance, right? And so I wanted to ask whether there are any hesitancies from the local partners to collaborate with the World Bank Group after like having in mind the history with structural adjustment programs, or does that just function without any?
Well, that's a very good question. I mean, first of all, to be clear about the structural adjustment programs, they were largely from the IMF in the 1970s, which sort of pushed around actually that you should decrease social sector spending. More recently, the IMF has actually released guidance to say the opposite, that you should not actually cut social sector spending during fiscal consolidation, and that there should be a social sector floor. So, but having said that, I must say, particularly coming to work from the Global Fund, there's a lot of hesitancy for people at the Global Fund for working with the World Bank. Many of my colleagues at the Global Fund, came from MSF, and so I have to say there's a certain, I don't know what the right word, you could almost say hostility even. But then, to be honest, the social sector people who work at the World Bank are very different. Actually, they're almost all, they're all actually nice people. So I think that part of it is, getting to know it. Because I think the world has changed since those times of structural adjustment and co-financing and stuff like that. But I think it's what I would say is that in general, though it's not always the case, the World Bank is not that great at community engagement and working with NGOs. But having said that, since I work a lot with NGOs with the Global Fund, in order to make financing sustainable for NGOs, you have to build the architecture so that the public financial management system can contract with NGOs. Otherwise, once the Global Fund stops funding the NGOs, then they'll fall apart. And that's what happens in the Global Fund, say, for example, in Romania. So we call that social contracting. We see working with the World Bank actually very beneficial. And actually, it was the World Bank project on AIDS in Brazil that started the whole social contracting position in Brazil. And Brazil's very, very good at contracting with NGOs. So, or at least was. I don't know really what's happened post-Bolivia.
I have a question that's come through. So the question is about what role can the Global Fund play in ensuring that national programs are funded by blended finance that are focused on reaching the most underserved communities that you actually want to reach in a way that's centered on human rights and meaningfully involving society?
Well, that's a very good question, particularly for the Global Fund. I mean, the Global Fund sees itself as being an answer to all those questions. So, so because the Global Fund works, I mean, largely, I mean, kind of the sort of main ethos of the Global Fund comes out of the AIDS and, and human rights. So there's we have a whole human rights department and so we try to do a lot of work on human rights, but we have an issue around sustainability. So we can fund things in that area, but we find it very difficult to make that sustainable, actually. So, so we have a complex mechanism in the Global Fund called the country coordinating mechanism, which is unusual because it includes civil society. So that actually is one of the benefits of the Global Fund is this whole CCM mechanism. But to be honest, the CCMs, depending on the country, are actually so often very problematic because they both are the gateway to Global Fund funding, but also they also have some vested interests. So it makes it very difficult often for us to work beyond AIDS, TB, and malaria because the partners who are very active on the CCM are particularly interested in their specific diseases and not really that interested in working on broader systems issues, actually. So I do think that no one is saying that the Global Fund grants would be completely eliminated. The idea is to have more than one instrument. So, I mean, anybody who's studied economics would know you should kind of use portfolio theory. You should have more than one instrument because if one doesn't work, it's good to have another one. It's almost like redundancy too. So what I would argue is that this kind of blended finance approach, has properties that the Global Fund grant does not have because generally we have a much closer relationship with NGOs and human rights, but we don't have such a strong connection to the Ministry of Finance, and we don't work so well on broader structural issues like primary healthcare. So we can do those things by blending with the bank, but still continue to pick up the human rights angle with our grants.
Questions in the room? Yeah.
So thanks, Michael. I found it really convincing. It sounds like it's a really, really, really situation for everyone, the development banks, the global finance, the national governments. But for my very short career in global health, those are pretty specific examples, and actually the vast majority of funding isn't dispersed that way. So I was wondering whether you could reflect on what are the big constraints for rolling this out more. And also maybe in a more positive light, you've worked on a couple of examples. Is there any lessons of why those were successful particularly?
Well, I am reflecting on that still. I mean, because in the end, it's down to people. And so I think the case of Pakistan was, this surprising constellation of forces, particularly this the person who was the task team leader for in Pakistan, in Pine, who's Burmese, and she's amazing. She really went out of her way, and she's super good at coordinating across partners. And without her and other people, including we had the Global Fund, the person at Gavi who was and we had been kind of working together for a couple of years. It's hard to see how you can make it's very personality dependent. And so, how can you move it to more structural approach to that and not make it so personality dependent? And I wish I had a good answer to that. And going back to the issue around, isn't there a certain level of animosity against the World Bank? I must say that generally from a lot of the public health kind of sort of more GHIs like the GFF, Global Fund and Gavi, there is kind of a certain level of hostility. And then, to be honest, doesn't help because WHO has a certain level of hostility also. So because there's a certain level of competition at the country level between WHO and the bank. And but what also doesn't happen is that it doesn't really come from the development partners, particularly the bilaterals who are really the ones who are funding all these organizations. So I think the missing part really is the British government, the Norwegian government, the US government, which are funding all these agencies, if they could be persuaded and see that actually. And I don't really know. There's now a new initiative by both the Norwegian government and the British government to look at the future of the global health architecture called the future. I was going to put it in the slide. The future global health initiative, the future of global health initiatives, and if it is doing, FCDO is doing a review as well. So I feel that because of the post-COVID space, there may be an opportunity to. Well, there may be an opportunity to change the whole architecture, but to be honest, I'm very nervous about, generally, I don't think that often works. So I feel this might be a better way to do that, because it doesn't require necessarily changing the architecture.
I have a question that's come through. It's a bit picking up your point about when you're trying to align the different partners' goals around when you're going to do this blended lending, and how do you kind of come to an agreement on what performance or outcomes you're going to then measure? Because as you said, everyone has a slightly different objective function.
Well, it does seem like this primary healthcare, thing is kind of a useful building block, because if you look even at the UHC monitoring index, you can pick out some of the indices, that are common both to us, say for the Global Fund, and also, for UHC more generally in primary healthcare. And so we're able to get TB in as a tracer condition for infectious disease. So if you look at the UHC monitoring index, TB is actually one of the indices included, actually, of the 106 indicators. So, and this isn't the role for WHO. See, the problem that WHO has generally had is that they develop these indicators in isolation, like you should do this, like as a country, but they should be thinking about, can they be operationalized in a World Bank project? Can you actually collect the data in a meaningful time? Can it be audited, something like that, which they tend not to worry about. And so they're not really part of the system. And so they're actually producing indicators that are separated from, and I had a lot of problems involving WHO in the indicator discussion with the bank, which I found very surprising. And we started doing seminars for WHO people, because it should be a win-win proposition with WHO actually. But I think that it obviously doesn't work for all indicators, but I do think an umbrella platform around either primary healthcare or UHC tends to be able to bring together the partners. So it'll bring together Gavi, the Global Fund, and the GFF at the very least. And then NCDs have to be included kind of for each.
Any questions in there? There's another one that's come up in the chat. There's one in the room. Yes, please.
Hi, Bianca, I'm a researcher at ODI. I work very closely on this, so it's extremely interesting. My question is more picking off on the previous one, on the division of labor more broadly outside of specific financing models between the MDBs and vertical funds like the Global Fund, especially in the context of the reforms of the MDBs that now a lot of the shareholders are asking them, finance climate change, finance global health. How do you see the future of that fitting into the division of labor amongst the players?
Well, I think you're asking a couple of different questions, because one is about climate change. So, I mean, we have a big issue, which is that the level of resourcing needed for climate change, is huge. And so is that going to crowd out spending in health, because everyone now is getting on the climate change thing? Or is this an opportunity for global health to actually tap into this large sums of money, that are going to be coming in for climate change? So, I mean, I've been working on trying to get money out of the Green Climate Fund for work on solarization of health facilities. I must say it's been quite a struggle, actually. So what I would say is that I think it's kind of unlikely that the global health will be able to get money out of these new climate funds. But I do think that to be honest, most of the work, a lot of the work is around mitigation and climate, and low and middle income countries are not and the health sector are not the major contributors. But I think on the adaptation front for climate change, that should be built into sort of anything, including pandemic preparedness, and is something that the Global Fund, Gavi, and other organizations can help with, actually. Telemedicine. I would say community health workers, for example, having not fixed sites, but actually, mobile health workers is actually one of the solutions, like, say, for example, in Pakistan, in relation to the floods, for example, to have and more access to mobile health, both telemedicine and cell phones, so digitalization. So I think those are the kinds of things that we could work on. In terms of the reform of the architecture, I don't really know what to say. I don't think the division of labor is clear. Because on jointly held systems like human resources, it's really not clear what the role of the Global Fund is, or on supply chain or something like that. But But actually just having one organization, I mean, I don't know, should there be so many different organizations? Should there just be one organization? I don't know. It's a sort of a broad question about markets itself. Like, should there just be one car company or something like that? I don't know. But the way the architecture works now, I'd be nervous about structural reform, which tends, anybody who's worked on the NHS should be like nervous about structural reforms because they tend to actually make the service not work. Actually, so if you can find solutions that kind of win for everybody, that might be an alternative, which is why I'm pushing for a finance approach rather than structural reforms. But I think the Norwegians will probably recommend structural reforms. So it's worth reflecting on the fact that they were the ones that caused the problem in the first place. So it was like Tori Goodall who created Gavi, who created the GFM. So it's like good for them to say that now it's a problem.
Coming just at the right time. We're close to wrapping up. I have a question from the chat. I think it may be useful to kind of shift the discussion. It's around, there seems to be some volatility in the market at the moment, and on your reflection on the blended approach, how is that at the moment impacting your ability to raise grants in any of the programs that we just discussed?
Well, we're not going to the private capital markets. So these are, you know, the World Bank, I mean, notwithstanding the question about the broad reform of the MDBs that, you know, to allow them to, you know, they have a AAA credit rating, which I think one of the areas that they're nervous about expanding their line of credit. So it's not really a problem. I like to work with the bank. I think the question becomes, do governments want to borrow, you know, and generally, I have to say that if you get down to like IDA rates, it's a bit surprising, but they seem to want to borrow actually like at IDA rates. So like, so if you're able to actually lower, you know, you don't have to give pure grant financing. If you can give sort of basically interest-free loans, I mean, obviously it has to be for things that the government is interested in, like primary healthcare reform, UHC expansion. They tend to be quite interested.
We're coming close to the end. I'm happy to take one more question from the room.
Yes. I think I can actually, thank you very much. This has it's been really very insightful. I just have a question regarding domestic financing, how that relates with the blended financing that you just mentioned, that you just talked about rather. In the course of your work, have you really evaluated to see if any of the case studies that you've mentioned today has really affected or impacted sustainability or domestic resource mobilization? What I mean by domestic resource mobilization is that, do you think the blended financing mechanism helps government to domestically generate more resources over time compared to if you've been doing the previous parallel investment at global level?
So in terms of domestic, I mean, first of all, it depends on, you know, the type of country you're talking about. Like, you know, are you talking about like complex operating environments, fragile states like Somalia? Are you talking about, you know, low-income countries like Malawi? Are you talking about middle-income countries? Because I think they're all slightly different. But I think generally what you see is that health rises with income. So health spending will rise with income. It's like a superior good and actually accelerates as your income increases. So, but sadly, that's overall health spending. And so what you see mainly in low-income countries is that health spending is increasing, but it's coming out of out-of-pocket spending, actually. So it's not coming from public spending. So, you know, in many low-income countries, 70% of health spending is from out-of-pocket spending, not from government spending, actually. So I think what we really want to see is an increase in government public spending on health, actually. So, which is what we're not necessarily seeing. And I think that there's like a particular issue about that in the, you know, particularly now, since there's so many constraints about expanding fiscal space in health. But what I would say is that generally, if you take a loan out, say rather than grant financing, that's a pathway to sustainability because it's a dialogue with the Ministry of Finance. Like, for example, when I was giving the example of community health workers, it's about getting the recurrent budget to pay the salaries for those onto the Ministry of Finance budget. Because if you don't do that, then it won't be sustainable. So I do think that it can actually, you know, bring money into the health sector that way. And the second point generally is, I mean, if you believe that health investing is like, you know, human capital production. So like if you're decreasing, say, for example, child mortality, then that's actually going to improve productivity of the health of the society in the long run, actually. So it's you know, that's the generally argument of the human capital, that investments in health and education will improve economic performance because of improved productivity of the workforce.
Okay, well, we've slightly gone over actually, but thank you to everyone coming. Thank you to those of you online. I'm sorry we couldn't get to all of your questions, and thank you to Mike for a really interesting topic.
All about